Hello, I'm Dr. Raggi from francescoraggi.com. Welcome to one more show. Today we have a star with us. We have Paul Marik. He is author of Mat Plus Protocol. That is very famous protocol for the COVID treatment. He is celebrated, decorated professor, and he is heading of the ICU unit as well for the West Virginia Medical School, and he is chief of pulmonary and critical care medicine. And he is one of the most important personality in the world involved to identify a cure for the COVID. So, Dr. Marik, welcome, and thank you very much that you are with us. And in today's discussion, I want to start about the treatment of the sepsis that you have found. And please explain us something about your work and your fantastic discover.
Well, thank you kindly for inviting me, and thank you for that introduction. So, I'll begin straight away with sepsis. So when we talk about sepsis, we're talking about a person who is infected with a bacteria, and sepsis refers to the host response, so the person's response to the bacteria. So in many cases, it's not really the bacteria that's killing the patient, it's the host response. And William Osler recognized this over 100 years ago, that in most circumstances, it's not the bacteria that's killing the host. So what happens is the host immune response generates a whole host of inflammatory mediators. So these are inflammatory proteins we call cytokines and chemokines. And there's really good data that it's these proteins which actually harm the host. So it's not really the bacteria. There are some instances where bacteria make a specific toxin. For example, Clostridia difficile produces a toxin, botulism produces a toxin, but in most instances, it's not a toxin produced by the bacteria, it's the host response. So therefore, you want to give antibiotics to kill the bacteria, but that's not going to take into account this profound inflammatory response. So that's why, we came up with this idea that you need to treat the inflammation. So that's how we came up with the HAT protocol, which is hydrocortisone, ascorbic acid, and thiamine. And what we show is that vitamin C, given intravenously, is a very potent anti-inflammatory drug. It's anti-inflammatory and it's antioxidant, because part of the problem with inflammation is you get oxidant injury. Then when we add a corticosteroid like hydrocortisone, it acts at multiple sites to decrease inflammation. So corticosteroids are drugs that have potent anti-inflammatory properties. And what we have shown in the laboratory is that corticosteroids and vitamin C act synergistically. So they act together to protect the host and the cells against damage from this inflammation. So that's how we came up with our protocol for HAT therapy.
And how did you discover the cure of sepsis?
Yeah, so like most things in medicine, it's not like you go out to find something. It kind of happened surreptitiously by accident. I had a patient in the ICU. She had overwhelming sepsis. She was dying from sepsis. She was in respiratory failure, cardiac failure, kidney failure, and I knew she was going to die. So, when a clinician is faced with that situation, you've got to say, well, what can I do that's not conventional to try and save her? So I had heard about Dr. Fowler's work on vitamin C. So I quickly looked at his paper and I thought, you know what, I'm going to try it. I thought, you know what, I'm going to throw in corticosteroids because we had a long interest in steroids. So I thought maybe the two would work together. And to my utter amazement, the next day when I came to work, I thought she would have passed away. She was significantly better. She was off all the drugs to support her blood pressure. Within a few hours, we took her off the ventilator. And within 4 or 5 days, she left the ICU.
Fantastic.
And people say, well, it's one case, but you know what? It's a patient. It's a real patient who demonstrated a remarkable change. And that kind of set the course. Since then, we've learned a lot. And one of the most important things, and I'm sure you recognize this as a clinician yourself, is timing is really important. So we didn't kind of recognize it initially because the patient came to the ICU, she was sick, she was dying. You don't wait. And we treat the patients early. Now, what's happened with many of the studies looking at vitamin C, they've waited an inordinately long time
I
to
know.
treat the patient.
I
And
know.
I think, so what happens is, they give it 24 hours or even longer after the patient presents. And what's happened by then is that this whole process of inflammation is so well established that it becomes much more difficult to reverse. So I think that's one of the biggest failures of these studies, because they don't really reflect what happens in real world. And we now think that, if patients are going to be treated later, and we obviously don't recommend that, because I think when patients come to the ICU, you give them antibiotics straight away. There's no reason not to give them antibiotics. Why would you wait? We would suggest giving the vitamin C and steroids at the same time, because I think that's where it's most potent. However, if for whatever reasons there's a long delay, then we think we need much higher doses of vitamin C. And I think that's what we've learned. We obviously don't recommend waiting, because no disease benefits from waiting and no treatment. So I think that's such a key factor, is early treatment. However, if for some reason treatment is delayed, then we would suggest a higher dose. The
And
other thing that's
there are
the
no
other thing,
there are no
sorry,
reason there are no reason to wait because vitamin C is dangerous.
there's no reason to wait. It's a
Yeah.
safe drug. Vitamin C is a safe drug. So what's really important, you ask a good question, is that human beings and guinea pigs are the only species on the planet that cannot make vitamin C. We've lost the ability to make vitamin C. So all other species, when they become stressed, when they become infected, make vitamin C. It's a natural hormone. It's a natural hormone. It's absolutely safe. So there's absolutely no downside. It's, why people argue, I don't understand. Animals make vitamin C when they're stressed. All we're trying to do is to kind of replace what the body would normally do when they stress. It's very safe. And so give it early.
Yeah, yeah. And can I ask you? I think you have read the paper of Klenner and Pauling. And what did you think when you read that works of this great scientist?
Yeah. So, I think Dr. Pauling, he was a physicist. He was not a clinician.
Yeah, yeah.
He recognized that vitamin C had, special properties. As a physicist, he understood the molecular structure, and he recognized that vitamin C had, very important clinical properties. But he wasn't a clinician, so that was a disadvantage he had, because us as clinicians, we understand how things work at the bedside. But obviously, it was through his work that he popularized the use of vitamin C. And he did a study in patients with malignancy, and he recognized you had to give it intravenously because you don't get adequate levels orally. And so there was a study which was done trying to replicate what he did, but they gave it orally and it didn't work. So they tried to discredit his work. So I think he was a pioneer in vitamin C, in that, he identified this as a really important molecule that has enormous clinical benefit. And he also recognized that to get high doses, in particular situations, you need to give it intravenously.
Yes. Yeah. Okay. Come back to the sepsis. How common is sepsis in the world? And what was the death rate before your treatment, your discovery? And what is now in your center?
Yeah, so that is a good question. Obviously, COVID has changed things a lot. But previously, bacterial sepsis was one of the commonest causes of death in the world. The numbers are not quite clear, but about at least 20 million people maybe died from sepsis. So it's a very common disease, particularly in elderly people. And so sepsis is a spectrum from infection to sepsis to severe sepsis to septic shock. And as you go down that continuum, the mortality goes up. So if you have severe sepsis, the mortality is about 20 to 30%. But once you progress to septic shock, it's up to 40%. And in lower income or resource poor countries, the mortality for septic shock can be as high as 40 to 50%. So it is the commonest cause of death in children under the age of 6. And it is a common cause of death after cardiac disease and cancer. So sepsis is an important medical condition.
Yeah, yeah. And what is now the mortality in your center? It's very low.
So the mortality is about 5 to maybe 10%. And obviously, the important thing is sepsis is a very, very heterogeneous disease. This means that not everyone who has sepsis looks the same. So, you have a young person who maybe has a urinary sepsis, who's otherwise healthy, who will do quite well. On the other hand, you may have a 70 or 80-year-old man who has heart failure, who has kidney disease, who then gets pneumonia. And what happens is that he just has not the physiological reserve to withstand it, and he dies, often not from sepsis, but from his underlying disease. So it's important to recognize that it's a spectrum. William Osler said that pneumonia is the old man's best friend, because what he was saying is many old people, that's how they die. They die of pneumonia, not really of old age. So that, many of the patients we see who die are not the young people who we can treat early with reversible disease. These are people with liver disease. These are people with cancer. These are people with bad lung disease. So it is a spectrum, but there's no question that, in those people, but, there are still people in their 40s and 50s who get severe sepsis, who do not have underlying lung disease, underlying diseases, and who die. And I think those are the people we need to treat aggressively. Much like our first patient, she was in her early 50s. She had no other comorbidities, none. So those are the perfect people that you want to treat aggressively. And if you treat them aggressively, and it's important to recognize that it's not just vitamin C, it's antibiotics, it's corticosteroids, it's taking good care of the patient.
Yeah.
And vitamin C and steroids play a role. And I think those are the people who do best with this protocol. Obviously, there are going to be old people, elderly people who have lots of underlying disease in whom the sepsis pushes them over the edge. But in other people, it's a treatable disease. I think that's the important point, that although lots of people die from sepsis, it's a treatable disease. The key is early treatment.
Yeah. And also the fluid management, I know that you are also very active.
Oh, yes. So, yes, my friend. Yes. So you ask a really good question. So, it's complicated and it's very politicized. And, people who develop sepsis are not volume depleted. It's not like these people have diarrhea and have lost a lot of fluid. And there is this absurd notion, and it's unclear where it came from. And I think maybe from the failed Many Rivers study. What happens is a study gets popularized, people believe it as gospel and follow it. So I think following the river study, people got into this idea that you've got to flood patients with fluids. And we absolutely believe, I think the data is now overwhelming and conclusive that sepsis is primarily not a volume depleted disease, and giving them large volumes of fluids kills patients.
Yeah.
I think we can say that quite convincingly. So therefore, the management of sepsis is a conservative, rational approach to fluids. It's a rational approach to hemodynamics. It's very early antibiotics and early vitamin C and steroids.
Yeah, yeah. And I've seen that you have had a new vitamin, the thiamine, vitamin B1. What benefit thiamine have had to the treatment? What
Yes.
is the reason?
Yeah, so that's a good question. I think the core treatment is the steroid and vitamin C. We think that the thiamine acts together. Obviously, it's a very safe molecule. It's vitamin B1. So for a number of reasons, firstly, many patients who get sepsis are thiamine deficient, particularly elderly people, people on a poor diet. And thiamine is very important for energy metabolism. One of the problems with sepsis is cells can't make energy. They can't make energy called ATP. Thiamine is absolutely essential for energy production in the Krebs cycle. So that's why we use thiamine. Thiamine also has anti-inflammatory properties, immunomodulating properties, and also theoretically it protects the kidney from vitamin C. So I think, it's a combination, it's a combination of drugs that work together. The specific impact that thiamine has is somewhat unclear, but you know what? It's so safe. It is so safe. So, why argue about it when someone is dying? Just give it to them, just give it to them.
Yeah, you cannot have any kind of problems. So yes, but one more question. I've read your works and I've read that the cortisone and the vitamin C together can act in a special mechanism. It is the endothelial dysfunction, and it is very important also for many other diseases like autoimmune disease, cardiovascular problems, and so on. What is your idea? Can this therapy may be effective also in other diseases or problems? Have you did you think about this? Because the endothelial dysfunction is so important today.
Yeah, so the endothelium is very important in coronary artery disease. It's important in diabetes. So there is data that vitamin C is helpful in diabetic patients because they get endothelial disease and coronary artery disease. But you ask a really interesting question because COVID causes an endotheliitis. It causes a vasculopathy. And that's why we think vitamin C and steroids has a particular role in COVID, because you're absolutely correct. The endothelium, is such an important organ, so to speak. And vitamin C and steroids have enormously protective effects on the endothelium. So, when the endothelium gets damaged, that's when you get leaky capillaries, you get clotting, you get vascular disease. So, microvascular disease and protecting the endothelium is just so important. So you're absolutely correct. Many acute diseases affect the endothelium. So, for example, pancreatitis, pancreatitis is an inflammatory disease that's not due to bacteria. And yet we know that vitamin C and steroids are helpful in pancreatitis.
So you are using in your center this kind of union between cortisol and vitamin C also in other conditions you are testing?
Absolutely. So, I think the model is sepsis, but there are other diseases that look like sepsis. For example, we had a patient with toxic epidermal necrolysis, which is a terrible inflammatory disease of the skin, mediated by inflammatory mediators. And again, we showed that vitamin C and steroids together had a potent effect in protecting, in improving the skin condition. So I think in many acute inflammatory conditions, such as pancreatitis is a good one because it's acute inflammation that's not due to bacteria. So vitamin C has a role. Things like, toxic epidermal necrolysis, which is an acute inflammatory disease of the skin. So I think it has applications in other acute inflammatory diseases. It's a really good point.
Yeah, yeah. And now, can you please explain us a little bit about COVID and the MAT Plus protocol?
Yes. So obviously what happened is, we had developed the HAT protocol for sepsis, and then COVID came around. And there are a number of very similarities and overlaps between sepsis and COVID. The important thing to recognize is that patients with COVID don't die. It's not the virus that's killing them. It's not the virus. And so it's much like sepsis. It's the host response to the dead virus. The host mounts this profound inflammatory response. And we kind of recognize this early on. And I think now autopsy studies have demonstrated that people who die of sepsis, it's really not the virus. It's not the viral attacking the host, what we call viral cytopathic effect. It's a dysregulated immune response. So that's why we adapted the HAT protocol to COVID. So that's how we came up with the METH plus protocol. And the METH stands for methylprednisolone, ascorbic acid, thiamine, and heparin. The heparin, because we now know, or we knew then, that as you said, you get damage to the endothelium, you get activation of clotting, you get clots forming, both within the small vessels and big vessels. So it's kind of common sense. What do you do if a patient has clotting? You give them an anticoagulant.
Mm-hmm.
So that's why we added the heparin. Obviously, the steroid and the vitamin C was because of the inflammation. And we know patients who progress to the pulmonary phase of COVID have overwhelming inflammation. And so we know that methylprednisolone is a very potent anti-inflammatory drug.
But not at the beginning, right?
Okay, so you ask a very good question. Yes, so I think when one looks at COVID, you have to look at the phases. And this is something which people don't recognize. So you have, the incubation period. You then have the symptomatic phase where people have, fever, malaise, headache. That's the virus is still replicating. So that's due to the virus replicating and the immune response. However, once patients on about day 8 or day 10 progress to develop shortness of breath in the pulmonary phase, that's the host inflammatory response. So your question is a really good one, because in the early phase, steroids are harmful because they promote viral replication. But once the patient has progressed to the pulmonary phase, the virus is dead, which is really important because giving an antiviral agent is not going to work because the virus is dead. You can't kill something that's dead. And what's happening is you're having a response, it's the host response. So that's why you have to give anti-inflammatory drugs. So, recently colchicine kind of emerged on the scene. So colchicine has mild anti-inflammatory properties. And what has been shown is that if you give it early, it helps prevent progression to the pulmonary phase because it's an anti-inflammatory drug. So, so in that respect, there are a number of really very obvious overlaps between sepsis and COVID, because they're both due to an abnormal, dysfunctional host immune response. I think you've got to treat them slightly differently. Bacterial sepsis is much easier to treat. You give antibiotics and you can get it under control. The problem with COVID is these patients develop a profound inflammation. So this virus triggers a very profound inflammatory response. And much like sepsis, the earlier you treat, the better. There's no question. So one of the problems and I think we saw this in Italy, where patients just presented late and people didn't treat them aggressively. Once patients develop progressive lung disease, it becomes much more difficult to reverse. So it's like septic shock. The longer you wait, the more difficult it is to reverse.
Yeah.
And COVID lung disease is the same. So once patients develop features of COVID lung disease, so this is not day 2 or day 3, this starts day 7. That's when you want to treat them aggressively. And I think the Spanish have shown this very nicely. They looked at the use of corticosteroids, and they found that if you gave corticosteroids early on the floor, early in the ICU, had a marked improvement in outcome. However, if you gave it after 48 hours in the ICU, it was not of any benefit. So again, it gets to the whole thing about timing. Timing is really, really important.
Yeah, yeah. And also the dosage of cortisone, it should be very aggressive in the right moment. It's very important. And also I have read the melatonin can be also useful. And I've seen that is in your protocol. Could you explain us something about this molecule, melatonin, I mean?
Okay, melatonin, yes. So you know what it's a really interesting question. So what we did with HAT therapy is we added melatonin to HAT. When we did HAT, we said, well, is there anything we can add to HAT therapy that may make this even better? And we looked around, we looked at all the molecules, and we thought melatonin was a particularly interesting one. So we called it MHAT. And when COVID came around, we thought, well, you know what, melatonin may work. So melatonin is a very interesting molecule. So firstly, it's not only made by the pineal gland, but made by other cells in the body. It's a very important anti-inflammatory drug and very important antioxidant. So it's, a lot of people think that most of it comes from the pineal gland, but it's also made by the GI tract. It's made by inflammatory cells. And it's a very potent antioxidant. It allows mitochondria to function normally. And mitochondria are important because they make ATP.
Yeah.
And melatonin is a specific mitochondrial antioxidant. So, we added melatonin to the meth protocol because, it made common sense. At that time, we didn't have good data. But now, whether it was luck or just good common sense, there's now really good data showing melatonin has a very important role in COVID. So there was a paper out of Cleveland Clinic that showed people who take melatonin had a significantly reduced risk of getting COVID, significantly reduced risk. There's now a paper out in New York which looked at people on ventilators and showed that if people were taking melatonin, they had a significantly reduced risk of dying.
Yeah.
So again, like vitamin C, melatonin is so safe. It is an extremely safe molecule. It actually has no side effects. The only side effects may be you feel a little bit tired. But when someone's critically ill, who cares? Yeah. So it's very safe. Yeah. And it has very important anti-inflammatory, antioxidant, and immune-enhancing properties. Yeah. So, at first we added it because we thought it would make sense. But I think there's now data showing that it actually has, quite remarkable effects in patients with COVID. And I think the point about COVID is that much like sepsis, which is you need multiple medications, multiple targets. There's not one single thing you give. You give antibiotics, you give hydrocortisone, you give vitamin C. COVID is exactly the same. You need multiple drugs that act differently, that work together. And I think because COVID is such an awful, aggressive, very bad disease, you really need a combination of medications.
Yeah, yeah. I have read that you use also ivermectin, ivermectina, and
Yes.
as I know that it's useful in all the phases of the COVID, and so it is a new treatment and is effective. Can you confirm?
Yeah, so that is a good question. So, we, Kelly and Wagstaff from Australia published a paper in April on ivermectin in a laboratory experiment. So it did get our attention, but at that time, there wasn't much clinical data. Over the months, ivermectin has emerged as a very, very effective drug for COVID. So it's been shown in really good studies and randomized controlled trials to protect in prophylaxis. So people, particularly household contacts who are exposed to COVID, if they take ivermectin, it significantly reduces their risk. It's important. In healthcare workers who take ivermectin, significantly reduces their risk of getting COVID. We know in people who take COVID early in the disease. So if you get COVID, you don't want to just sit around doing nothing. You want to do something to prevent progression. So ivermectin is very effective in preventing progression. And surprisingly, in sick people in the hospital in the ICU, it reduces mortality. And what makes ivermectin such a remarkable drug is it has antiviral properties. So we know without question it actually enhances killing of the virus, but also has very important anti-inflammatory properties. So again, we're coming to the inflammation. So ivermectin has anti-inflammatory and antiviral properties. And this is a very, very safe medicine. It's been used since 1985, mainly to treat parasitic infections. It's on the WHO list of essential medications. About 3.7 billion, that's with a B, billion people have been treated with ivermectin for various parasitic diseases. So we know conclusively that it's a very safe drug. It just so happens that ivermectin has very special properties against viruses. So it turns out to be a wonder drug because it was given to us on a platter. It's just there. It's anti-inflammatory, antiviral, and it's very safe. So you know what harm do you give in giving patients ivermectin? So as I said, it's part of our strategy. So when patients present early, we say give them vitamin D, give them vitamin C, give them ivermectin, no steroids. When they present late in the hospital, steroids, IV vitamin C, and ivermectin. So, it's a multi-pronged approach using multiple drugs depending on the phase of the disease.
Yeah, absolutely right. And one more question. So about kind of prophylaxis, and so at home, what the people can do easily. You said vitamin C and ivermectin also can be useful. So also in this way, in the early stage. But for prophylaxis, to be healthy and stay healthy, what can be done?
Yeah, so
What supplements are you using if you are using?
yes, that's a really good question, particularly now, particularly in winter, particularly in Italy, which is quite north. So we know that during winter, particularly if you're north of 40 degrees latitude, people are vitamin D deficient. We know, we know absolutely if you're vitamin D deficient, it increases your risk of getting COVID, it increases your risk of being hospitalized with COVID, and from dying of COVID. And we know if you give vitamin D supplements, it prevents that happening. Interesting. Dr. Fauci himself, although the NIH won't endorse vitamin D, Dr. Fauci has publicly stated he takes vitamin D and vitamin C. So he knows. So what we recommend is that everybody on this planet, particularly if in winter, particularly in the northern countries, and those who have people of color who can't make vitamin D, people who are obese, elderly people who don't make as much vitamin D, take vitamin D. And if you take 3,000 to 5,000 units a day, it's very safe. It's very cheap. So it's a very effective way to protect yourself. We would also suggest vitamin C. Again, it's very cheap and works together with the other compounds, 500 milligrams twice a day. Also to take melatonin if it's available in your country. Some countries you can't get it. In the US, it's available over the counter. So to take melatonin at night. So these are very simple things that people can do. Now, obviously, you still want to wear a mask. You want to avoid big gatherings. There's no question that, public health measures are still really important. We can't ignore them. So those are things people can do. And then I think in very high risk people, that there may be a role for ivermectin. So if someone in your family has COVID, the likelihood is that close family members will get COVID, about 50%. And in that setting, I think they should take ivermectin. So we have a prophylactic dose for ivermectin. So what I would suggest for your listeners is we have a website, flccc.net, flccc.net. And on the website, we have all our protocols with the dosing and the recommendations. I think we have an Italian version that's translated.
Yes. I will write the link. I will write the link in the video so people can go directly there. And think that in Italy, ivermectin is not possible to buy. We cannot buy here. It's only for inside the hospital we can use. So we don't have this kind of bullet here in Italy. But have you ever heard about angiotensin 1.7? Have you ever heard?
Yeah, so in terms of the ivermectin, we're hopeful that the WHO and the NIH will start looking more favorably on ivermectin and that it will become more available throughout the world because we think it's important. So you ask an interesting question about angiotensin. So actually, it seems that ACE2 levels, people think if you have high ACE2 levels, it's a bad thing, but actually it's protective because of the effect of angiotensin 1.7. So there are studies in which people give angiotensin 2. There were studies in ARDS and it seemed to improve outcome. One of the interesting things is that men do much worse than women who get COVID. And one of the reasons is the ACE2 receptor is expressed on the X chromosome. So women express much higher levels of ACE2 than men. So paradoxically, giving ACE2 will increase angiotensin 1.7 levels and may be protective in COVID.
It could be the key of the problems, the angiotensin 1.7. But it's not so common, this drug. Here in Italy, it's very difficult to obtain this molecule. And did you give a try to this molecule?
Yeah, so it's not available in the US. I think there were, it was looked at experimentally, and there were experimental studies, but I don't think anybody is actually pursuing, actively research in that area. And obviously it's interesting because, as I said, I don't think it's one drug, it's a combination of drugs, and drugs that target angiotensin may have a role in COVID together with, corticosteroids and other medication. You're right, yes.
Yeah, I have read a paper of an Italian medical doctor, Paolo Lissoni, and he found very good results in COVID with this molecule. And so it is a promising molecule. Maybe in the future, in the near future, we can see something about this. Uh,
Yes. So,
so
I think COVID is a really interesting disease. It activates lots of different pathways. So, I think there's a potential for lots of different drugs. For example, serotonin. We get serotonin release. We get histamine release. So there may be a role for serotonin blockers, histamine blockers. We don't know. It's a very challenging disease. And I think we'll need to use multiple drugs to treat this very complicated disease.
yeah. We live in a strange world, and it's difficult today to find a solution for this complicated uh, disease. But I think that the right information is essential, because there is a lot of confusion also in our scientific community, and we need to clarify everything because people are dying. So it's not ethical to do wrong way, or where there is money or other kind of interest. We need to do we need to share the right information, and we are here for doing this today with you. So Dr.
So
Marik.
I just want to echo what you said, Dr. Raggi. I think the most important thing about this pandemic is we need to talk the truth. I think in no other time in recent history is the truth more important than it is now. And there's so much misinformation, misinformation amongst doctors, and then it creates enormous confusion. And I think it's this confusion which is causing so much anxiety, so much depression. So I think the most important thing is, we need to speak the truth. The truth needs to be told. And I think the truth is very empowering. If people understand the disease, if doctors understand the disease, then it gives them some power. But it's all this terrible misinformation that is causing this, it was making this tragedy even worse. I agree with you.
Yeah, we need to educate people, and please share the video. And so, Dr. Marik, thank you so much to be with us today, and I hope to see again in the near future.
Well,
Thank you.
thank you for speaking with me today. And we just wish everybody, long life and good health. And we have to overcome this awful pandemic. So thank you.
Thank you too much.